several differences between the two techniques. Drug-eluting beads cannot reach neighboring hepatic arterial branches that are smaller in diameter than the bead size. Therefore, DEPTase can stop the blood supply from the hepatic arteries, but cannot stop the blood supply from the portal vein or the hepatic sinusoids. Lepidol, on the other hand, can pass through the hepatic sinusoidal region to reach the portal vein and surrounding the tumor, to temporarily block the sinusoids and arterial microcommunications. Two things to bear in mind, and we talked earlier, Professor Sibolt mentioned that as well earlier, that a combination therapy with immunotherapy and TACE can prolong survival, the Emerald one. So the procedure that was used in the Emerald was C-TACE, solely almost, and most patients were from Asia, and so it's unclear whether to choose one technique maybe will be influenced later on by whether we want to combine it with immunotherapy or not. There are mixing reports regarding the superiority of one technique over the other, and with both techniques, comparable doses of chemotherapy can be delivered, so differences can be pointed out. Creating the palatal drug emulsion may be not reproducible. It's very different whether we push the doxorubicin or the drug into the lepidol or we push the lepidol onto the chemotherapy agent, and how many times we mix the emulsion, everything is count. Maybe drug-eluting beads may be more reproducible, but bear in mind that there are several beads types in the market. And different techniques have several little different side effects profile, with post-embolization syndrome and worsening liver function may be a higher risk with C-TACE, with lepidol, and biliary complication and hepatic artery damage is more frequent with DEPTase. And now moving to some technical principles in TACE, super-selective embolization, meaning cannulating the most distal blood supply to the tumor. By that, we will achieve a higher drug dose within the tumor and reduce liver toxicity by delivering the dose almost exclusively into the tumor. For that, we're using small microcatheter, usually 2.4 or 1.9, but even smaller microcatheters can be used. And we use axial imaging during our procedure, either with cone-beam CT or diagnostic CT. And we use vessel detection software and using flow diversion techniques to direct the drug more effectively into the tumor, and I'll show you several examples. This is our hybrid room. We have a special Lixari system which combines seemingly two systems, one fluoroscopy system and CT, like full diagnostic CT. Basically, the patient is lying on the table, we get arterial access with fluoroscopy, move the patient to the CT, acquire CT arteriography, and bring the patient back to the fluoroscopy to do the hepatic arterial embolization. Here you can see the angiographic image of the right hepatic artery and the corresponding image acquired from the CT with contrast injection from the same location. You can see the superior spatial resolution in that CT image. Using vessel detection software, we mark the tumor and the catheter, and the software analyzes which vessel is supplying the tumor. In this case, you can see that there are 3 different tumors on the right lobe. So initially, we perform lobar TACE, but we know that lobar TACE is usually not sufficient, and second procedure was planned. Here is an angiogram from the second procedure. On the right circle, you can appreciate the residual enhancement of the tumor, while here on the green, the 2 other tumors were successfully embolized previously and are not enhancing. And to super select the single vessel supplying the tumor was very challenging. When there is a steep backwards angle of the vessel from its origin vessel, the main vessel was occluded. So what we did here, we used flow diversion technique in which we embolized with coils the main artery, and we delivered the lepidol basically backwards. You can see on the yellow line the lepidol droplets going back to the tumor. In a third procedure, we again use vessel detection technique. After detection the tumor, supplying vessels from the CT, the path was projected into the fluoroscopy screen, and under the fluoroscopy we target these vessels, here both from the right and left hepatic arteries. And this is the end result what you can see here, this is two non-contrast enhanced CT. So all the bright white is the lepidol mixed with doxorubicin post-embolization. There's very dense accumulation of lepidol within those tumors. Another flow diversion technique is performed by balloon occlusion microcatheters. Here we inflate a balloon in the tumoral vessel in order to direct the drug more distally, unlike the previous cases I showed. When we inflating the balloon, the blood pressure in the tumoral vessel is dropped, so there is less resistance and more drug can be delivered forward into the tumor. Also, this occlusion prevents backwards flow and non-target embolization. Of note, these microcatheters are currently not available in Israel. TACE, as was mentioned earlier, is non-curative treatment. Many attempts are done to increase tumor response. One approach is to combine TACE with ablation. We discussed this earlier as well. In this meta-analysis, data showed that TACE combined with microwave ablation for tumors larger than 5 centimeters was significantly superior to TACE alone for both tumor response and overall survival. In this approach, first TACE blocks tumoral supplying arteries, and then microwave reaches much larger ablation range, which is high temporal efficiency. Local microperfusion of tumors decreases significantly after TACE, reducing the possible perfusion-mediated tissue cooling effect and increasing the ablation range. The deposition of the lepidol of the TACE causes stronger heat conduction and tumor local edema. And I will show you one case from that sort. So this is an example of a procedure in which we combine TACE and ablation. Microablation was planned using our ablation planning and validation software. The software is by Texomed. What we do here, you can see a short video. This is, okay, perfect. First, we mark the tumor. We segment it completely on axial imaging, here in the orange. Then we choose our needle. And we choose the margin that we would like to achieve. In HCC, usually it's 5 millimeters. For colorectal liver mets, we go wider. We need 1 centimeter margin. And using this software, we plan our path. We see the area that is predicted to be with the microwave ablation. We make sure that there are no surrounding collateral damage to vessels, pleura, etc. Here you can appreciate that the tumor is very close to main portal vein, and so this will affect our ablation margin, and this needs to be taken into account. So during the procedure, first we perform angiogram, detect the tumor, as I've mentioned and showed you earlier with our software detection, and perform TACE. Then we move the patient to the CT and place the microwave antenna into the tumor. And this is the immediate procedure CT when we can appreciate the large ablation margin going all across, very close to the vessel basically. And the ablation margin here is it's much larger than was expected with just ablation alone. Now, post-procedural, we would like to validate our ablation margin. We compare the pre and post ablation margin. You can see that next to the portal ablation margin, there's more narrow margin, but basically the TACE will be able to cover for this margin. So to summarize, TACE is effective, safe and effective treatment. Sterilization is still lacking, but utilizing the advanced imaging technique will hopefully improve patient outcomes. That's it. Thank you. And I would like to invite our next speaker, Dr. Michal Mauda from Shiva Medical Center. He will discuss radioembolization for hepatic liver malignancies.